where data can be collected from claims. So we've got a lot of data that a lot of quality improvement projects that can be collected from doctors' prescribing patterns, and that can be done through claims data from Medicare and other pharmaceutical benefit schemes. And these ones can be done easily, but again, sometimes it does involve a particular cost. Other data can be retrieved from electronic health records, and also so something to think about. Also, we use a lot of prems and proms, so patient reported outcomes and patient satisfaction. Surveys are done all the time in hospitals, so some of these can be relevant for you to capture some of the data that you would like to capture as well. Now, data analysis is very important. So you need to think about in advance, when you design your quality improvement project, what sort of data you are going to capture and how you're going to analyze it. So it's important that you need to think about whether the data that you'll be capturing, you need it like for the beginning and the end, or you need to measure it on a regular basis. You also need to think about using a benchmark source. So as I mentioned before, sometimes you don't have the beginning point. You know already that an intervention has already been in place, and people haven't captured the baseline data, but you want to actually see how well it's been doing. So you need to think about another institution performance and compare it with that. You also need to think about having dedicated resources to perform the data analytics. So, for example, sometimes you might need things like Excel or SPS or any other statistical package that you will need to analyze your data to. So these are all the things that are important when you consider that. Now, data reporting. So this is also something else that you need to consider. Now, who needs the data? Who needs to know about the data? And is it the frontline staff? Is it just the doctors and the nurses and the pharmacists who are involved in the patient care, or the leadership and the board? Is it something serious that would be important for the leadership and the board to consider? How frequent do you need the data to be reported? Is it daily, weekly? Is it monthly? How should the data be displayed? Now, a lot of modern hospitals now, they've got data displayed in dashboards and charts, and it's something that is used a lot in the US to ensure or to give the impression to patients that, management and the board is on top of hospital quality and making sure that the patient is the focus of the care. Now, where to report the data is also important. So once you collect your data from your project, how are you going to, where are you going to report it? Are you going to send it by email? Are you going to put it in the organization bulletin? Or are you going to just present it to, say, monthly meeting that you have as part of your hospital or part of your committee meetings as well? And that's why it goes back to knowing the organizational structure is really, really important, because you need to know, once you do an improvement project, who you're going to send it to. Okay, now this is something that I also would like to also talk about. So quality improvement fundamentals. So normally when you do any quality improvement, you need to choose a framework that you're going to use, and making sure that the framework is robust enough to capture your baseline data, your changes, any improvement that you're going to make. So the one that's very familiar to many of us is the PDCA cycle, which is a plan, do, check, and act. So this one, you need to plan what you are doing first, and then do what you said that you're going to do. Then check that what you did is right by collecting data, and then act on anything that went wrong to avoid any errors of the same nature in the future. And there are some variations of this cycle, and there's 8 steps in there. So the first one, identify opportunities. So think about a project that's meaningful to your organization. Sometimes it's good to find a simple, easy project, but I think something meaningful or something that's going to be important to your organization will be able to have the engagement of leadership and having people interested in it as well. Set your aims, make sure that you've got aims that are clearly articulated and the reasons for that, and also the gaps and the rationale for choosing your aim. You need to make sure that you also establish some measures, and we talked about using the SMART criteria. Select the changes that you are going to do and make sure that the changes will have a direct effect on your project. And also implement the change. When you implement the change, make sure that you actually have a record of what you have done, and spread the change around, and make sure to also follow up too. Okay. Some tools to ensure high quality and safe care. So tools are provided, so provide clinical decision support, provide best practice guidance. Many tools, for example, you can have an allergy tool, you can have a drug interaction tools, you can have a tool whereby people, a reminder to check maybe height and weight of the patients if you are prescribing IV antibiotics. So there is many decision support tools that you can embed in your electronic healthcare tools. Now, I'd like you to present, I want to present a couple of studies for you. And just pick and just talk a little bit about it. I'll give you references at the end. So this is, I don't want to talk too much about the actual project, but just give you an idea about what's there and follow what I've mentioned before about getting the team on board and the criteria. So this one, it was done in Australia. It was about evaluating the impact of various medication risk reduction strategies on medication errors. So many strategies have been put in place in a large hospital to decrease medication errors. So medication errors remain the second common type of preventable incidents reported in Australian hospitals, which contributes to a significant mortality and morbidity. So this project was really about putting together some initiatives in a 450-bed large Australian hospital. And the initiatives included 2 arms. One of them, it involved new pharmacists charting roles. So they got some pharmacists, trained them and on how to involve patients and care in timely documentations of medication histories. So they didn't end up, so the pharmacist in that role, they had, their role was very specific about only, as soon as a patient is admitted, to only chart medications on the patient charts. Instead of having the nurse or the doctor doing it, they had a pharmacist role only doing that. But also one of the roles was to include the patients or the carer in charting this. They also had other initiatives in the actual intervention system redesign strategies, which involved redesigning the discharge process and modifying the electronic prescribing system to provide decision support to prescribers and patients to ensure appropriate care, particularly alerts about thrombophylaxis. So an alert came out every time you discharge a patient about, okay, and does the patient have appropriate thrombophylaxis or not? So in many surgical, for many surgical patients, particularly the ones that get discharged soon, to avoid thromboembolism, they, according to the hospital protocol, they have to have aspirin or IV thrombophylaxis prescribed to them. There was also alert prescribed about other chronic health conditions. So this intervention included both charting, changing the role of the pharmacists by making sure that they are involved in charting the medications, but also including reminders in the electronic healthcare systems or decision support systems about prophylaxis charting for patients who are getting discharged, and also making sure that the alerts about adherence to guidelines. Now, for this particular project, the pharmacist who was involved in this, she managed to do some baseline data, collecting medication errors, number of prescribing errors, and reporting errors were collected for 6 months. Other outcome measures also were included, like patient satisfaction surveys. So this particular project involved many outcome measures. And these are the outcome measures that the pharmacist who was involved in the project collected. So as you can see, that's a list of all the outcome measures. You've got pre-intervention, so that's a baseline, and at post-intervention, so that's after, which is 6 months after. And that's the difference in p-value between the baseline data and the post-intervention data. As you can see, p-value was significant for all of the outcomes. So this particular project involved about more than 60,000 patients records they've looked at. And because the pharmacists had access to electronic medical records, it was easy to collect that much information for this cohort of patients. Total number of medication errors reported before the intervention was 656. After the intervention was 534. Medication error reduction ratio was quite significant, as you can see from the numbers. Number of reported prescribing errors, again, was significant after the 2 initiatives that the pharmacists put together. Prescribing error rate, again, was less because there was reminders to prescribers to make sure that they adhere to the guidelines. And also there was another reminder about the thrombophilaxis. And there was other measures regarding also medication errors, but the ones also that caused harm, not just the near misses. And percentage of patients who reported satisfaction with their medications. As you can see, there was a significant increase in the satisfaction rate after the intervention. And that was captured using the normal survey data that we get from patients, which is the PROMs and PREMs that I've talked about. So that was a very successful project. It needed a lot of engagement from not just the pharmacy department, but also the hospital management board, and also the person who was involved in the ongoing quality assurance of the hospital. And also they had a specific, I think that particular project had a student who was involved in doing a research project that collected that much data as well. And the student was in placement during the project, so it was easy enough for them to capture, to having access of this data. So thinking back about all the, what I've said about the project earlier on, you know, about the components of a successful quality improvement project. So this project had also successful components, and it managed to show some improvement at the end because it had the leadership, it had the specific outcome measures, it had the electronic medical records in there, it had engagement from leadership. So it ticked many boxes in there. And there was actually the implementation for practice. So the standardized system that was put in place had the potential to achieve the best possible patient's outcome. And the patient-centered strategies also improved patient satisfaction, as I mentioned to you. And it was successful because the pharmacist was also involved in multidisciplinary teams at all stages of the medication, not just on admission, but also in medication discharge as well, and making sure the prophylaxis was prescribed and there was adherence to guidelines. So moving on to another case study, and that one, again, that was a successful healthcare project. And that one looked at impact of redesign of a clinical decision allergy and drug interaction alert in an electronic prescribing system. So we've shown... am I okay to still go ahead?
Yes, Professor.
Okay, all right.
I think the record system there is
No,
disturbing.
that's
Okay.
okay. Okay, so that's another successful project that was done in quality improvement. And again, that one was specific on drug allergy. One of the projects that I was involved in earlier on is that there wasn't enough documentations of allergy in hospital patients, and always when patients get admitted, it's always forgotten. So in this particular project, we managed to include a decision support alert by making sure having a trigger system to make sure that the prescriber or the person who's putting in the information for the patient has got a reminder to check for allergy, but also for drug interactions. Now, I'm not sure about you, if I've worked in hospitals and community pharmacies before, and sometimes when you dispense items or when you prescribe, you always get this, alerts all the time about checking drug interactions. Now, not all drug interactions, as we know, are clinically significant, and sometimes you get, you keep pressing yes, I want to dispense without really checking, because you think most of the time it's not really important. So this particular project looked at so they wanted to reduce the trigger alert fatigue and making sure that actually prescribers are quite alert to the important clinical interactions that they have to look at. So they picked 50 drug interactions and had a team of prescribers and pharmacists looking at to assess the clinical significance of these alerts using risk measures. They also looked at the frequency of overrides and based on the literature on adverse events. So that team, which included pharmacists and doctors, they looked at all of that, and they managed to have a list of alerts, and they have a list of alerts that are clinically important, managed to put them back into the electronic healthcare system, and they deleted all the other alerts that were not necessary. Now, just to let you know, normally when in the prescribing process, so you order the medication, sometimes the medication, if there's an allergy, or if the doctor is prescribing a medication and that's interacting with another one, sometimes it does trigger an alert. And if it does trigger an alert, then sometimes you accept the alert and cancel the prescribing, and sometimes you override the alert if you're too tired and just continue prescribing. Now, imagine if this is an important drug interaction, or if this is a drug that the patient is allergic to, that actually will involve in harm to a patient. So we wanted to make sure that the alerts that are in the electronic medical records are actually significant alerts, and it's not just something that doctors can just push back, or pharmacists when they are dispensing. So after that's just a table of results, and as you can tell here, that's just a pre-intervention and post-intervention. So you can see that the total number of medication audits about more or less the same, but the percentage of alerts overridden it wasn't actually significant, which is a good thing, because it just meant that after the intervention, there was only a number of alerts, only the specific ones, only the dangerous ones were maintained in the system. Now, the alert trigger rate was significant, which meant that after the intervention, which meant that most doctors were actually quite alert to the drug interactions, or the alert that they got. Now, also, that's just another table reporting pre and post interventions. So the number of reports incidents related to overriding alerts. Before it was 5 incidents, but after the interventions, there was no incidents were reported, which meant that the alerts were good enough for doctors to make sure to go and check for them, because they were much lower than before. And as you can tell, also the number of alerts related to drug drug allergy were much less, and the number of alerts to all the other alerts was much less as well after installing the system. So the implication for practice, using a risk assessment evidence-based approach to deactivate the commonly reported allergy and the drug-drug interactions, reduce alert trigger rate, and using the same concept to reduce various alerts has the potential to reduce unnecessary alerts and improve the system usability to clinicians. And also this has got the potential to reduce reports in harm and near misses. Now, I know we don't have much time, but I just want to present you the last case here. And this case, it's not something that I was involved in, but I found in the literature, and I wanted to make sure to show it to you because that wasn't a successful intervention. And I want to actually show you why it hasn't been successful. So this one was done in Tanzania, and it was done as a randomized controlled trial. And it was to test the success of a maternal healthcare quality improvement intervention in improving quality of care. So they had 12 primary care facilities where this quality improvement intervention took place. The intervention included many other strategies or many interventions, but it looked at the providing training to the nurses there. It also looked at mentoring some of the young nurses, and also it looked at supporting supervision of some of the young nurse and the infrastructure support. The outcome measures that this intervention looked at, it was the structure, process, and outcomes, and they also included satisfaction with the care, newborn counseling, proportion of women receiving IV antibiotics, and presentation of anemia in mothers giving birth, and also presence of hypertension. So they looked at many outcome measures, looking at the three processes that we did look at, which is the structure, process, and outcome. Unfortunately, I don't know whether you can see this, but none of the processes that they looked at showed any improvement after the intervention. So you could see here the confidence interval and the relative risk, it was all below 1. Even the patient experience was also below 1. So there was no improvement in patient experience. The outcome measures, again, it was all below 1. Maybe for a patient perceived quality, it was only above 1.22. Only 22% of the patients said that they received better care for that. Now, unfortunately for this one, the multifaceted quality improvement project resulted in no meaningful improvement. The evidence suggests that it was due to both failure to sustain a high level of implementation and failure in the theory. So what they said that, unfortunately, the quality improvement intervention targeted at the clinical level in primary care, but to start with, the quality was actually quite poor. And even though they had changes in the infrastructure, but there was poor infrastructure. They didn't have enough nurses to actually deliver the care that they wanted. There was not enough training, even though they did provide training, but there was low provider competence. The nurses, even after the care, they were not competent enough, and hence it wasn't effective. And unfortunately, that was one of the unsuccessful quality improvement projects. So in conclusion, I'd like to share with you that organizational structure, to be able to have a successful hospital quality program, you need to make sure that the organizational structure and governments include that as a priority. Leaders need to be engaged and accountable from the beginning. You also need to make sure that you've got a measurable platform that enable you to share the process. And also making sure that you've got an infrastructure to be able to measure, modify, and improve. And also making sure that you've got the ability to change systems as well. And that's it for me. If we have time, and it's up to you, I'm happy to have either a discussion or have breakout rooms. But if you can think of a healthcare project that you want to share or something that you've been involved in, I'd like to hear about it. Or you can present it either using one slide or just present it like how I'm presenting now. And just talk a little bit about any successes and challenges, what made it successful, what made it not successful, or even if you want to talk about something that you would like to do and have some feedback from all of us here about, ideas to look at and barriers. So I'll stop sharing now and I'll hand you over to the moderator. So it's up to you, however you want to run this, but I'm happy also to have any questions.
Okay. Okay, Professor Hanan Khalil, so thank you for your lecture, and we will begin our discussion. If you have any question, you can raise your hand or in chat box before our breakout room. Okay, there is one question, Professor. Professor,
Yes.
there is one question.
I'm just
Okay, in PDCA cycle is important for quality improvement fundamental. And the question is, from your experience, which step do people skip most often and at what cost? In PDCA cycle, which cycle that people skip at most? Okay,
yeah.
thank you.
Thank you very much, and that's a very good question. I think people always forget to check how the project is going, and sometimes they omit this. So what they say is that I'm gonna capture some outcomes at baseline, and I'm going to capture it at 6 months, without actually making sure to check that the intervention is working. And sometimes you can actually reduce a lot of unwanted workload and a lot of unwanted resources by just making sure to check that the intervention is working. People understand what you are doing, why you are doing it. So I'm currently doing an intervention for palliative care patients, and what we've planned to do, we've collected already some baseline data. I'm planning to have monthly meeting with the nurses who will be implementing the intervention to make sure that they actually understanding what they are doing, making sure that I understand the problems that they have on the ground so that I can address it as soon as possible. So really, this is one of the biggest problem, is just forget about the project, only do the baseline and then just the final collection data without having an ongoing buy-in and making sure that your project is being implemented correctly.
Okay. Okay, thank you, Professor. So there is so much question, but we have to more discussion in very much project, because the theme of this lecture is quality improvement project. So we can start. So many audience here will begin to decide to which is one you join in one group in breakout room. So you can start to discuss in 5 until 7 minutes. So you must join in 7 minutes to main room to presenting your project. So Professor, there is one question. Which bahasa which language we must use in presenting our project? Professor.
Of course, bahasa
Which yes, which language?
Sorry,
Must be in English?
Yeah.
Okay. So
or whatever you want. Well, I won't be able to understand you, so whatever you want. I mean, if Ingi can help, so.
No, I think it should be supposed to be in bahasa English. Yeah, in English language.
Okay.
On that one.
Okay, thank you. And the discussion begin from now, and we will start in main room in 11:20. Thank you, everyone.
Hanan.
Yes. Sorry, Ingi, you're frozen.
Hanan, would you mind if we give student like a 10-minute time for discussion? So we'll be back to the main room around 11:25. Is it okay? Okay, okay, thank you. Maybe you can have break as well. I'm sorry, you're still mute.
Yeah, sure, that's fine. That's okay.
Okay, yeah, you can have a break as well. So we're waiting. Okay, thank you. For all other students, hello, just join the breakout room.
I will have to leave at 2:45 because I've got another meeting. Is this okay, do you think?
Okay. I will ask to everyone to come back in main room so we can start the discussion. I think can someone help us to assign everyone back to main room? I hope for the committee to can help me to move the participant to main room. Because of Professor Hanan Khalil, there is another meeting after this, so we will start to discuss our project here. As Professor said that for the example from Professor about how project can improve our healthcare quality in medication safety risk reduction strategy and the maternal healthcare intervention and then redesign of clinical decision allergy and drug interaction alerts in electronic prescribing system. So everyone, you can discuss your project here with English. Actually, if you can with bahasa a little, so I can describe and professor will give feedback for you in your project. Okay, so I want one of group to join with us and presenting from group ARS2 maybe. Please share your screen and we discuss about your project.
Okay, thank you, Mbak Vanda and Prof. Hanan. We will present our discussion. The quality improvement from our group. There's 5 of us. So we will talk about, next slide please, Mbak Dewi. The booking online for patient. The background of our project is there is still several hospitals in Indonesia still use manual booking system. So the waiting time for patient is
very long time, above 60 minutes in Indonesia. Our project is through queue booking online for patient. It's because the before project is waiting time is too long, above 60 minutes, and too much document, wasting time for patient in hospital, and then patient complaints for a long waiting time in admission, and then uncertainty number 2 for quota for patient. And then the after project is the reduce of waiting time, digitalization administration or paperless, and then improving quality, patient satisfaction, and patient safety in this project. Next slide. Our program for QQ booking online for patient. One is redesigning administration system. The example is the bridging of the system information management hospital with online program, and then redesign the administration process in hospital, redesign payment process for online booking, and then redesign medical service pathway, hiring technical provider for online administration process, human development, training program for booking online, controlling with PDCA cycle, that's which Prof. Hanan already told. Evaluation system for this booking online, and quality and patient satisfaction survey for our booking online. Thank you.
Okay, thank you very much, Ms. Leonie, for the very amazing project for the QQ. Maybe Professor Hanan Khalil, you have make a feedback for us. Thank you.
Yeah. Thanks very much for presenting. It's a big project, so and you're trying to capture many outcomes. So my idea would be you're doing many changes, many interventions. So I would probably go back and see maybe it's best to change 1 or 2 things rather than changing 4 or 5 different initiatives, and then look at the outcomes about that is relevant to each initiative. Patient satisfaction is very broad, but you need to think about something that will actually directly measure the changes that you will do. Yeah, so that's really my feedback to you. Do it slowly, do one initiative at a time, and make sure that the outcome measures is really going back directly to the change. It's not going to be, because many times we capture things like, mortality or hospital readmissions and all of that, but these are not direct outcomes to a particular intervention. It would be good to go back and think about something that's very specific to the intervention that you are going to implement and what you can measure. Otherwise, it will be really hard for you to keep track and to say that that's a beneficial intervention. So that's my comment.
Thank you, Prof. Hanan. Maybe I would like to share some things in Indonesian hospital, Prof. Hanan. In Indonesia hospital, there's 2 kinds of doctor, home doctor and non-home doctor. Home doctor, which the doctor will sit in the hospital maybe 7 to 8 hours at a time, but the non-home doctor will sit maybe 2-3 hours. Then they will go to the other hospital. Maybe it's not like in Australia, just one hospital, 1 doctor for 1 hospital. In Indonesia, 1 doctor can practice in 3 hospitals. So the queue on booking online is, I think, is very important, because in 2-3 hours they will not admit to the doctor. The doctor will go into the hospital, so the patient will not get the medical service from the doctor, like that. Thank you.
Thank you.
Okay. Thank you for Mrs. Leonie, and thank you for Professor Hanan Khalil that you gave feedback. So the point is how we choose the most specific specific intervention, maybe a professor, so we can choose the most specific outcome for the project. So this is very important for the next presentation. So I will give the next opportunity to a group from breakout room ARS1. Maybe Mrs. Julia or Mrs. Nanny, you can help me to presenting. Hello. If you are not ready, maybe from the ARS3 for Mrs. Miss Rismi, and then Mr. Hendrik, you can presenting your project with us. So the professor can give the feedback.
Hello.
Thank you.
Hi, can you
I
hear
can
me?
see your, yes.
Hello, sorry, can you hear me? Okay, I'm from RS3. I'm Hendrik. We would like to present quality improvement in pharmacy unit. Slide. Our project is reducing the waiting time in pharmacy unit to make dispensing medicine with using e-prescription. The standard of waiting time for dispensing medicine is 60 minutes. Right. And for the main components in this success in this project is the first one, hospital management information system. Second one is training for human resources, and the third is discipline, and the last is use standard operational procedure properly. Next. And of course, we have also challenges. We have 5 challenges. The first one is lack of human resources. The second one is misdiscipline. Too many items in one prescription and too many patients. And also lack of knowledge in using e-prescription. Okay, thank you. Maybe that's all from our group. Maybe you have any suggestion or for us?
Yes, yeah, thank you. Thank you, Professor. You can give feedback for us.
Is this a project that you would like to do, or that's a project that you've done, or?
We would like to do.
Okay, all right. Mostly, you've already identified some challenges. Some of them are doable. The fact that there is lack of training in e-dispensing, I think this is probably the easiest one to handle. So maybe if you can have an intervention addressing the lack of training, so maybe half a day workshop for people, pharmacists or technicians that are helping to be able to use the e-prescription system and how to use it, that will speed things up. And make sure that the training is actually is done for new employees too, and for existing ones, so anybody who's coming on board. The other thing you said, staff resourcing. So I'm guessing there is not enough staff, pharmacists or technicians working to dispense.
Yes, Prof.
Okay. Are you able to, in Australia, sometimes you can write a business case to show how many, how many more staff you need. So in general, there is a staff, I think there is, in Australia, there is, I think one pharmacist shouldn't be dispensing more than 100 prescriptions a day. So you might go back and see how many prescriptions a day you're dispensing, and you need to have a look at the ratio of staffing that you have and maybe present a business case to management, how to increase the staff that you need to have to ensure safety. Because also when you've got too many prescriptions, you can present it the way that, you know, there will be medication errors that will reduce the safety and it will impact on the hospital reputation. So you can put a good business case to increase staff and to put it in the context of safety to patients, as well as safety also for the pharmacists and the staff working there. So these are two things you could change, I guess.
Okay, thank you,
Professor.
For your feedback.
Are we still have time, Professor?
I need to leave at 2:45, so we've got 2 minutes. Otherwise,
2 minutes?
We can close off. Yeah, 2 minutes. Otherwise, we can just close off. Yeah.
Okay, maybe just one question for the last professor. Maybe we can take any presentation anymore because the lack of time. So professor, like we have the project, so we must need resources, which is very costly for us, and maybe make the healthcare is more expensive for someone and somebody because of the improvement that we need always year to year. We gave improvement and that was very costly. So how do you think about this?
Look, that is a common problem when the improvement is quite costly. So you need to make sure whatever improvement you're going to do, it's going to be actually sustained as well. I was involved in a project whereby we had a very good improvement, but it was very costly. And you probably need to think about how to reduce the cost. Was the cost coming from equipments, or was the cost coming from staff, employing extra staff, or what was the cost coming from? And I think for us, the project that I was involved in, the cost was mainly from the equipment and the ongoing management of the equipment. So what we did was we had to not buy the equipment, but we needed to make sure to have a trained staff to be able to capture all of this and make sure that we have ongoing training. So the equipment that I mentioning, it was really a database system to keep track of wound care and wound healing times. And it's not just the cost of the system, but also the support of the technical support and the IT that's needed and all of that and the updates. So what we opted to do, instead of having the electronic system that, you know, was able to give us good photos for patients and all of that, we managed to employ additional staff, a regional wound consultant, to be able to train staff and to be also liaising with staff on the ground about what needs to be done. So I think cost is really, it's a big issue, but you need to think of creative way to reduce that.
Okay. Thank you so much, Professor. And this is the last of our session. Thank you for everyone who participating. And we are very honored to meet you, Professor. And thank you for the committee that this guest lecture will be held. And thank you for all attendees who participating. And we hope see you soon on the next Erlaga guest lecture session. Thank you. Good day, everyone. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much for inviting me.
Thank
Bye,
you so
everyone.
Thank you. Thank you very much.
Thank you.